down, I'll fly down to New Orleans. That city, so pretty, historic scene. And I'll take you, parade you down Bourbon Street. Oh, we'll see all the hot spots. We'll meet all those big shots down
With a lot of this stuff.
Okay.
Hi, we're
ready.
live.
We
Okay,
are ready.
good morning. Just kidding. Good evening. Thank you for joining us. My name is Kevin Winthrop. I'm a professor of infectious diseases and epidemiology at the Oregon Health Science University in Portland, Oregon. It's really nice to be here in Thoracic Park, or wherever we are, with my two esteemed colleagues, who I'll let them introduce themselves. Doreen.
Hi, everybody. I'm Dr. Doreen Drizzo-Harris. I am a pulmonologist at NYU Grossman School of Medicine in New York City, and I run our program in bronchiectasis and NTM lung diseases.
Rocio.
Good evening. My name is Dr. Rocio Hurtado, and I'm an infectious disease physician as well, just as Dr. Winthrop at Harvard Medical School, and I run the MGH Mycobacterial Center.
Great. I'm looking at our pictures on the screen, and we definitely used to look better.
Agreed.
Oh, well. Hey, before we start, though, we are going to do just a couple of housekeeping notes. One is you're going to get some polling questions to practice, and then we're going to do some during the thing. At the conclusion of the ceremony, there's a QR code on your table. Click on that for your CME, okay? Make sure you do that. And then you'll also find question cards at your table. If you'd like, you can write questions on the back, and someone will collect them from you and send them up to us. What else? Today, learning objectives. I mean, I don't know. We're just going to talk about NTM, incidence, prevalence, how to diagnose it, how to treat it. Rocio is going to present some difficult cases. We're going to weigh in on them. We're going to ask you some questions that don't necessarily have right answers, but we're going to give you our thoughts about it. So, with that being said, thank you for joining us, and we'll get going. Those were the objectives I just mentioned. And the agenda. Dinner is very important. Accredited. We are accredited. You can get mock points too, which is really exciting because I love the boards. And also, if you're not an MD, there's other options for you too. So with that being said, our disclosures, and we'll move on through that to polling time. So this is the QR code that you can scan and visit. Okay, here's the question. These are really just to practice doing the thing at your table. If you were a respiratory clinician in Jurassic Park, which dinosaur would you most likely, I thought it was most likely beat, but now it's most likely need your help. So the T-Rex, because it's roaring too much, the Velociraptor, hyperventilating, Brachiosaurus, long neck, long airway, that is a problem, and Triceratops, allergic to prehistoric pollen. So you can just for fun click something so you get used to doing this. And they're going to play music when you do these questions, and then eventually they'll show your answers. And this tells us how people voted. Okay. All right, we're not going to comment on this.
No.
Because it's a meaningless question. Okay, polling question, word cloud. Now this is kind of fun, and this is actually sets the tone for the talk. I mean, what comes to mind when you hear non-tuberculous mycobacterial lung disease, or NTM-LD? That's one of the acronyms we use these days. So you are going to be asked to tell us what comes to your mind. So go ahead and click on something, and we'll get a word cloud. Okay, so that's probably enough word clouding, but you can tell. What do you guys think about this? Is this how you feel?
Yeah, I like
Yeah.
it. Difficult's right in the middle, so I guess the symposium's going to help everybody in the room.
Yeah.
Long road, long road.
Old lady, I like that, old lady. Also old dudes, just so you know, that they are part of this. Maybe about 55% of women and about 45% are men. Okay, unraveling the complexity and epidemiology of NTM. So this is the pre-assessment question, which I think you will click on one of these choices. It sets the stage for what we're going to talk about. 69-year-old woman with fatigue, chronic cough, and known bronchiectasis is failing to improve after being seen at several urgent care visits. What would you do next? A, start treating her for NTM without any evidence of her having an NTM. B, monitor symptoms, repeat imaging in 6 months unless she worsens. C, proceed with evaluation as the risk factors are suggestive of NTM. Or D, treat her for pneumonia and consider IV therapy. So what would you choose? Okay, are we showing the responses or not? Yeah, we are going to show this, but we're not going to talk about them.
Right.
Until
But
later.
I think we can just say that looks pretty good. Yeah, we're going to
Next slide,
proceed.
yeah.
So let's talk about NTM. And then one more question though, which patient has the highest likelihood of NTM according to the clinical scenario described? A, 42-year-old woman with flu-like syndrome and COPD. B, 55-year-old guy with asthma and frequent flares. C, a 68-year-old woman with right middle lobe bronchiectasis and worsening treated opacities. Or D, a 74-year-old male with hypertension and a solitary lung nodule. Go for that. Okay. Thank you for answering. Again, I think people are on the right track. So let's get into the meat of the presentation. So this is, there's a lot of NTM species. Now there's 200 plus. And I will tell you the number of those 200 that are pathogenic is about 10. And there's about 2 or 3 that predominate 98% of NTM lung disease, MAC, abscessus, and Kansasii. And everything beyond that is either not a pathogen or really, really rarely a pathogen, and you should email somebody because we don't know what to do with it. This is some managed care data that I was involved in looking at a few years ago. And it was through like 2020, actually up through 2015, we did a couple analyses. But you can see that over this 7 or 8 year period, no matter all the lines are different age groups, there's commercial insurance, there's Medicare insurance, it doesn't matter. It's all going up in incidence in the US. And you can look at similar data from other countries around the world. We all see the same trends. And we all see the preponderance of disease in women. Again, it's about 60-40 or 45%, depending on what age group you're in, but it is more predominant in women. And I can tell you that just overall, I mean, all comers in the US, it's about 6 per 100,000. So, you know, it's about three times more prevalent than tuberculosis. And as you go up in age, you go up in incidence. In terms of the country and the distribution, this was actually a veteran study, so it's predominantly male patients, which I think was interesting. But we would see the same thing if we look at commercial databases, that the Southeast and some areas on the West Coast are kind of hot spots in terms of higher prevalence. And Hawaii is not on this map, but Hawaii would be the highest prevalence probably in the country. Why is Arizona prevalent? I mean, this is mainly because a lot of old people go there or they live there. It has nothing to do with the desert or the climate. Ken Olivier did a nice study a couple years ago that showed that the prevalence of NTM really correlates quite well with water vapor data in the air. And so if you look at the areas that are more moist or more humid, the West Coast, Southeast, et cetera, you tend to see higher rates of disease. And Hawaii, of course, is much higher. So Florida and Hawaii, when I think NTM, I think about Florida and Hawaii. and I'd rather go to Hawaii. No offense, but that's just because I like Hawaii. Anyway, but those are the areas probably, and Florida too has a lot of older people that come here and hang out for the winter or emigrate here. So those are reasons why there's higher prevalence. CDC surveillance data. This is a great project. This was something I bugged CDC about for years, and finally they did it. This is being done within the Emerging Infection Program. This is very recent data. I guess I already told you that the annualized incidence or prevalence is really 6 per 100,000 years or person years, so 6.1. This is in a number of jurisdictions around the country where you have complete capture of a population, and you actually have denominator data. They're looking at all cultures that come into these labs. The labs report to them. They track down these patients. They figure who meets case criteria for disease and who doesn't. So this is great epi, and it's been going on the last 4 years. So again, the incidence is 6 per 100,000 patient years. Mostly female, 63%, mostly white. But one thing that's nice about this, I think a lot of our data from treatment centers tends to be more white, more female. This is showing a little less white, a little less female. There's other people out there with this that don't necessarily end up at tertiary centers. Let's see. I think I'm turning this over
You're turning it over to
you.
me.
Yeah,
Yes.
talk about it. Yeah.
And before, I'll just put in a plug as part of our care center network. We're also looking into health equity and disparities and trying to uncover the traditionally less visible people who are living with bronchiectasis and NTM. And so there are definitely pockets where we see more post-TB bronchiectasis, more patients with sarcoid, and so stay tuned for more data. So this is, of course, a ubiquitous environmental reservoir, soil, dust, water, over 190 species of NTM with 30 major ones responsible for human pathogenicity. And the top three that Dr. Winthrop mentioned, MAC, M. abscessus, and Kansasii, and the guidelines are really focused primarily on the management of all three, and then it becomes a lot more art than science in terms of how we approach the others. But globally, NTM accounts, we actually see it in 10 to 30% of patients with non-cystic fibrosis. And in parts of the world, such as Asia, we see that 64% of NTM in China, for example, is attributed to post-TB bronchiectasis. So really where you are and the geography really matters. And this just highlights that there's a sort of relationship between the host and the pathogen. And so we've got on the one side, very low pathogenicity NTM, such as Gordoni, Paragordoni. And when we see these, we oftentimes think about aspiration and other types of comorbidities. And then we see the Malmoenses, the Zolgais, and some of the rapid growers also on the other side of the spectrum. And MAC tends to be somewhere in the middle as well. And so all of you and many of you are familiar with some of the traditional morphotypes associated with NTM. And so above and beyond the fibronodular bronchiectatic individuals, which typically tend to be more commonly female, many times with chest wall and or spinal deformities, about a 40 to 60% rate of scoliosis, mitral valve prolapse, right middle lobe and lingular involvement radiographically. Do remember that men still are seen, and the traditional phenotypes in men include not only higher rates of COPD with primarily fibrocavitary disease, but can also present with other presentations such as nodules, and also concomitant co-aspiration, which can present with lower lobe predominant involvement. On occasion, we get some of these patients who are referred with these nodules where our thoracic surgeons are suspecting malignancy, and that's a happy visit to pulmonary and ID where we can give them the good news. And some of those patients actually just with resection are managed appropriately. And then of course a whole host of other phenotypes with associated underlying structural lung disease, patients with sarcoid, ILD, pneumoconiosis, cystic fibrosis, of course. And some patients don't present like the textbooks, they present with the complications. And so now it's time for some post-assessment. So go ahead and load that up, and we'll go back to question number 1. 69-year-old lady with fatigue, chronic cough, and bronchiectasis failing to improve after being seen at several urgent care visits. What do you do next? Go ahead and vote. Great. Dr. Adrizzo-Harris, any comments on some of these responses?
I'm glad they went up from 86% to 95%. So yes, obviously, it's a talk about NTM. We want to evaluate them first before we treat them. So make sure we make a definitive diagnosis. And we'll talk a little bit more about, even when you do make a diagnosis, whether or not you need to treat them. So we'll get to that.
Absolutely. And moving on to our final question of this section, which patient has the highest likelihood of NTM lung disease? Cast your votes, please. Fantastic. And so I think we're all on the right path. As mentioned previously, many a times, even in our own diverse clinics, from the waiting room, we can identify some of these patients. So underlying pulmonary disease, bronchiectasis, really leads the pack, with almost 2/3 of our patients having that as one of their risk factors. And really, management of the bronchiectasis is really cornerstone as part of the holistic package for these patients. Up to anywhere from 1/3 to 2/3 of our patients have some level or degree of esophageal copathology, so esophageal dysmotility being incredibly common. Silent GERD, and Dr. Adrizzo-Harris addressed this yesterday at one of our other sessions, and so that's the key term, is that, and this impacts patient engagement, is that many times patients don't have symptoms, and so it's really hard to get individuals to follow these lifestyle measures. And then be aware of other co-diagnoses related to chronic inflammation or residual cavitary disease, co-infection with fungi, in particular aspergillus, and in old cavities, mycotomas. This is also associated not just with cavities, but concomitant steroid use is a risk factor. Co-infection with other NTMs in the series anywhere from 5 to 15%. And in our US setting, the most common combination is MAC and M. abscessus co-infection, which we can talk about later. And then this is a chronic inflammatory state, and there is a signal of increased risk primarily with squamous cell carcinomas in this chronic inflammatory state. Kevin, back to you.
Yeah, it's back to me. I'm going to make a couple comments so off the cuff. We did a population-based analysis in Oregon years ago, and so what we found was about 25% of pulmonary NTM is cavitary, 5% presents as an isolated nodule, and the rest was bronchiectatic, fibronodular disease. That was what we found.
Yeah.
The other thing I was going to comment on is that you talked about bronchiectasis, the biggest risk factor. We also looked at a huge cohort of bronchiectasis patients that didn't have NTM, and we followed them out for years. It turns out your risk of acquiring NTM is about 1.5% per year. So your bronchiectatics who don't have NTM, keep them close and do surveillance and follow them for a long time, because they will have a reasonable chance over 10, 15 years of getting NTM. The other question we looked at in this population-based analysis I was referring to is this, and it was a question about mortality. And we were always kind of taught back in the day that, well, this is a quality of life issue. It doesn't affect quantity of life, and it doesn't increase your mortality. And then Ted Maris looked at it in Ontario, kind of at the same time we looked at it in Oregon, and then there were subsequently a couple other analyses done, and we kind of all just found the same thing, that actually that was wrong. It does increase mortality. I mean, here, people with it were 23% more likely to die in 5 years, basically. So it does shorten your lifespan. So it is quality, it is quantity. It argues to the need to, identify patients who are going to benefit most from treatment, which Doreen's going to talk more about. it's important to talk to your patients about this, I think.
Yeah. Would you agree, Dr. Odrizo-Harris, that the pendulum is swinging with some of this emerging data on progression as well?
That we're seeing increased progression in these patients as we're starting to follow them
Yes.
now. And I think that's why the guidelines are geared towards treatment.
Yep.
But again, I think that's the hardest decision, to treat or not to treat. We can tell you what drugs to use, and we will go through that, but it still comes back to making that decision. I think that's the hardest thing we have to do in our practice.
Totally agree. These are some patients we're going to go through, so I'll just leave it there, but some examples.
My name is Caitlin Pastick. I'm a second-year infectious disease fellow in Boston.
I'm Angie. I became sick in 2017, diagnosed in 2018, and I'm really happy to share my journey with you.
Tell me about what you were thinking of when you heard this diagnosis of MAC or NTM. Did you have any concerns or worries?
I had a lot of concerns. Honestly, right before I was diagnosed, I had gone to my supervisor and filed for short-term disability. I work full-time, and it was hard to walk from one side of the room to the other. I was struggling so bad, I knew something had to change. Once I got the diagnosis, I was really worried I would never be able to work again. And my breathing was so bad, I was scared of it just not improving. And I had a feeling at that time life would never be the same, but it really was scary knowing how big of a deal this could be.
But luckily, Rosia cured her, didn't you?
Very long road.
We're going to talk about that. So in your clinical practice, how do most patients arrive with a diagnosis of this condition, and what are some of the gaps you encounter that lead to a delay in diagnosis, which the patient was just hinting at took her over a year to be diagnosed, and it's something we see all the time. So the clinical presentation and diagnosis of NTM, Doreen.
So when making a diagnosis, how do you interpret conflicting microbiologic and radiologic findings? So we know there's a delay in making the diagnosis first of bronchiectasis, and then we know there's another delay in making the diagnosis that they have underlying NTM. So by the time we see patients, most of us see them already when they've had at least a bronchiectasis diagnosis, and we're usually the ones sending the first sputum cultures on them. So definitely a delay in CT scans, a delay in sputum cultures across the board. But then when you have to make that difficult decision to treat or not to treat, it's quite obvious if they're extremely symptomatic, their CT scans, multi-lobe disease and progressing, and they've got numerous MIR-positive MAC, we're going to try and treat that patient. But that is not what we usually see. We usually see a patient who's either very symptomatic, but their CT scan may have minimal disease, intermittent positive cultures. What's most important to you, Rocio, when you're trying to decide who to treat and who not to treat?
Yeah, so really trying to tease out how much, in particular for patients who are living with bronchiectasis, I think one of the biggest conundrums is how much of the bronchiectasis-related complications are contributing to the clinical picture and the radiographic picture. Many of our patients are cycling through many antibiotic courses. Sometimes that also impacts the diagnostics, especially if the urgent cares have used a lot of macrolides and may decrease the detection initially. And then really trying to tease out, is there unexplained progression? Oftentimes, because it's much easier to treat these bronchiectasis flares, especially if they're colonized with other pathogens, we tend to aim towards treatment of the lower hanging fruit, traditional bacterial pathogens before we embark on a more long-term arduous road. And so, Kevin, any tips or tricks for the audience?
I have nothing to add. No, I would just echo what Doreen said, that there's a discordance often between the CT findings and their symptoms, and it can go either direction. Yeah. So a lot of times patients are like, God, do we really need to do another CT scan, or I don't want one, or whatever, because they feel pretty good. But I mean, I can't tell you how many patients feel great, and I scan them, and they got a cavity, or they have a lot of disease, or vice versa. So it really behooves you to do, both radiologic surveillance as well as microbiologic surveillance, and, obviously talk to your patients, see how they're doing. But this discordance can make the decision to treat difficult.
Yeah.
Yeah.
So I think when you've got cavitary disease, it's a little bit easier. We're all going to
Yeah.
probably really focus on treatment in most of those patients. But it's the nodular disease, underlying bronchiectasis, and I have to stress, we did a session last night. The most important thing to do up front, even if you're culturing NTM, is to make sure there's no other treatable etiology that's causing the underlying bronchiectasis. Because if they're recurrently aspirating and you treat their NTM, the NTM may go away, but their symptoms are not going to go away and their progression is probably going to continue. So work up that etiology. I do not believe that 40% are idiopathic. I believe that's just because we don't have the time to do the complete workup. It's probably much closer to 10 to 20% if we really do a thorough workup. And then if the NTM is still there, after you treat the Pseudomonas and the staph, and they're still not better,
Yeah.
because if they've got everything and you treat their Pseudomonas and they feel great,
Yeah.
well, then it's not their NTM doing it. So
Exactly.
really have to prove to yourself that the NTM needs to be treated. And then if you're going to treat it, obviously, you want to be doing it the correct way. So we're going to do some pre-assessments here. A 70-year-old woman with chronic cough and weight loss presents with worsening symptoms. A chest x-ray is inconclusive. Not sure what that means, but what should be your next step? Would you proceed with a CT scan to assess the bronchiectasis, refer for bronchoscopy for deeper sampling, schedule a follow-up x-ray in 4 to 6 weeks, or start empiric treatment for pneumonia? So vote now. Where I think we're good. All right, we'll go on to our next question. According to the guidelines, how should sputum cultures be collected to confirm NTM lung disease? Should you do daily samples for 3 days? Does that provide the most reliable result? One positive sample is enough to confirm the diagnosis. 3 separate samples collected over at least a week, or 2 same-day samples are usually sufficient. Okay, we'll come back to this question. All right, so as you know, sputum's really important in making your NTM diagnosis. We'll collect a specimen. There'll be a smear related back, as this nice one here. It's got a lot of positives on the smear. The culture takes time, sometimes weeks, and then we will go ahead and get an identification of the NTM, and then usually you should be sending for drug susceptibility, even if your institution does not do it. That is recommended for MAC and M. abscessus species. And we know that disease progression occurs in majority of patients who meet the criteria, and we'll go over the criteria in a second. There's lung function decline, and as Kevin already pointed out, there's an increased mortality. So you need to have all 3, clinical, radiologic, and microbiologic abnormalities in order to make a diagnosis of having NTM lung disease. So clinical symptoms, usually cough and sputum, but patients may have fatigue, night sweats, they may have hemoptysis. Radiologic, either bronchiectasis with nodular disease or cavitary disease. And then you're going to want to have 2 organisms on sputum, same organism on 2 cultures, or 1 bronchoscopic wash or BAL, or a biopsy that then grows MAC or M. abscessus. And there are lots of things that are going to go into our decision, as we said, as to what is going to make us treat a specific patient. So there are other comorbidities, their age, their sex, their other medications that they may be on are going to play a role. To talk a little bit about specimen collection. I'm not even going to read through this slide. I'm just going to ask our panel. Rocio, how good is sputum? How good is induced sputum?
Yes.
How good is bronchoscopy? What do you go to getting, and what is necessary to get sputum in these patients?
There's a lot of coaching involved in this part of the diagnostic pathway in terms of collection of sputum. Typically for our bronchiectatics who have some bronchorrhea, AM expectorated sputum, it can be very useful, but there's a subset of patients who, unless they undergo sputum induction, and ideally, if you're co-managing their bronchiectasis, which we would highly encourage everybody to be aggressive about, they can auto-induce at home with hypertonic saline. And so that really does increase the yield in terms of accessing specimens. But there's always a small subset of patients whom, despite all of your best efforts in coaching and hypertonic saline and all of that, may need to potentially progress to bronchoscopy. Kevin, how
Do you
are
agree?
things in Oregon?
How
Yeah, I agree.
often
I mean,
do you need bronchoscopy?
I'll just say, there's so many patients, the bronch's negative, and then I get a sputum on them, and it turns out positive. It happens all the time. So obviously we do bronchoscopy if we feel like we need to. But my thought on the sputum too, I mean, I do 3 specimens over 3 weeks. I do 1 a week for 3 weeks. That's what I do. I don't think there's a right answer about that, but you just want multiple specimens over some certain time period. The other thing I do, which is completely, is anyone here from the lab? That's good. So what I tell my patients is I tell them start Monday morning, put whatever you make that day in a cup and put it in the fridge. And Tuesday, add to it. Wednesday, add to it and bring it in at the end of Friday. And when you bring it in, don't tell the lab you did that and lie to them. They'll say, when did you cough it up? And you say, I coughed it up in the last 2 hours. That's what my patients say. Because for AFB, I mean, for routine organisms, that's a problem. But AFB organisms, that's not a problem. And you'll get a lot more yield because, we all get tired of the labs rejecting the sputum because there's not enough and there's too much saliva, things like that. So that's how I get around this, and I've found that has helped me get better yield with sputum, I think. So.
And it makes it easier for the patients if they can induce at home. But
Yeah.
yes, don't
Yeah.
send that same culture for bacteria because it will be positive then if
sure,
they've
for
been
sure.
home for 5 days.
Yeah.
The other small tiny point I wanted to make is sometimes we get referred patients who have only had a bronch. And I always do ask those patients, even though it may not necessarily be a diagnostic dilemma, to produce sputa, because if they grow it on sputa and we end up treating them, then we can use sputum as the monitoring.
Yep.
That's a good point.
So learning how to have your patients get induced is extremely helpful for following them, and we can talk about that more. So considerations for where we talked about when you decide to initiate treatment. The important things that may push you are your organism. Obviously, we saw that MAC species are somewhere in the middle of the spectrum as how virulent they are, but if you've got M. abscessus, you're probably going to lean on the side of thinking about treatment earlier, particularly if they're macrolide-resistant M. abscessus, if they have heavy smear positivity, cavitary disease, they're older, males have a worse prognosis, malnutrition, low BMI, we know increased mortality in that group, so you're going to want to try and treat them early. Immune deficiencies, definitely really need to think about that early depending on how immunodeficient they are, and Kevin's done a lot of work in this area, want to make sure they don't have progressive pulmonary disease, but also don't go on to have disseminated disease. And so, even inhaled corticosteroids are going to increase their risk of developing NTM and potentially progressing more significantly. And then you're going to want to think about what regimen you would have to give them, the risk benefits. Are you going to make them sicker than they are right now by the meds you're going to give them? And have to think about that. So if they're kind of on the borderline, I think it's extremely important to get to know your patients and follow them for a little bit. Remember, in most patients that are not immunocompromised, this is not going to be a rapidly progressive disease. So getting to know them a little bit to see how rapidly they are progressing sometimes is the best thing. And then once you can prove, because we often get patients who've never had another CT, I don't know if it's been with bronchiectasis and et cetera, some small cavities for 20 years, or it's been like that for 3 months.
Yeah.
So following them a little bit is really, really helpful. And then thinking about what your success rates are going to be. For MAC, in good hands, somewhere between 60 and 80%. I don't know, reaching the 80s sometimes is a little hard, but that's what the studies report. M. abscessus isn't going to be that good. Mesotheliense, if you've got a macrolide sensitive, yes, you might reach 70, 75%, but if you're macrolide resistant, 50% in good hands, depending if you do surgery together with that. So it gets much more complicated. This says less than 40% if resistant. So there are some studies really that are, really less than in the 25% range. And then remember, patients recur. I always used to think it was just a relapse of their prior, this is when I was very young, of their prior bug, but for the first studies coming out of Tyler, Texas, with Dr. Wallace there, showed that patients, a significant percentage, as high as 50%, were having new infections. And so your patients are predisposed to developing MAC, and in a large percentage, somewhere between 25 to 50%, within several years after you treat them and are successful, they are going to get MAC again. And so we have to start all over again. So is there anything else that really pushes you to start treatment right away in someone? Kevin?
I agree with everything you said. I think it's pretty rare to find people progressing quickly. I mean, there is that patient 3 or 6 months later has had a lot of progression. I think those tend to be people that are really skinny,
Yep.
low BMI, or they're immunodeficient in some way. But I think the BMI to me is a huge factor, and it really factors into, I also do what you do. I get to know my patient, try to get a sense of if they're progressing, but I also try to get them to gain 5 pounds.
Yes.
That might be more effective than a macrolide, to be honest. So,
Absolutely.
yeah.
So having nutrition counseling is really, really important.
Huge.
Rocio?
Yeah, I always tell our patients they never walk away in the first visit with meds at hand. I say we're getting the house ready, we're getting the party ready. And some people there's some non-progressors or who may have terminal comorbidities and whom, even though they meet criteria for the disease, if they're 97 and they meet criteria, but
Yep.
we wouldn't treat. That's an extreme example. I think the reinfection micro-recurrence story is a really interesting story. And we typically store our samples at the University of Texas. And it's a sort of engagement story, especially for patients who develop the MAC again in particular, because a lot of them feel very despondent and say, well, you just treated me for 2 years and here we are again. And we've detected many of these reinfections where then they have their own separate, we have to go back to the drawing board, and then a portion of them will have to get retreated again. But it allows them to sort of understand a little bit that this wasn't just the old MAC that failed to die. This is actually a new infection.
Right, and that's
Yeah.
a whole nother symposium on why
Totally.
people are getting reinfected.
Yes.
But you
Hot
want to say
tub.
something? What?
Hot tub.
Yeah, no hot tubs. Our patients are good with that. But I do want to come back to the BMI issue.
Huge.
And yes, great to have nutrition, but these patients are very complex. So sometimes it may be that the disease is very advanced, and this is just the signs. Once they start to have weight loss, we see the mortality increases. But why that's happening may be multifactorial. So anxiety and depression is extremely high in this cohort of patients. So having counseling help that. Eating disorders, separate from their NTM and separate from the meds that they're on, are also high in this population. So having access to at least look for those signs is really, really important. And I do agree with Kevin that sometimes just that weight gain improves the immune function in those patients, and they then start to fight the disease even before you start to get them on meds. All right, so back to our question. What do you want to do in this patient with chronic cough and weight loss, presenting with worsening symptoms, who's got an inconclusive chest x-ray? There's a lot of things we want to do in her, but what would you do as your first step? Thank you.
Amazing.
Oh, what happened? I think you're still voting. So the CT is the right answer here. We really want to assess your patient for a bronchiectasis and be able to follow them. Chest x-rays were really not good at diagnosing bronchiectasis until it's quite late stage. So CT scan early. And on our next question, how are you going to get samples to confirm the NTM lung disease? I think Dr. Winthrop gave us the answer to this one.
And while you're answering it, also, I was told if you have a question, you wrote it down on your card, just raise it and someone will come grab it from you.
And at the end, we'll do some rapid fire.
Yeah, and so as you're answering this, I think there are many other answers we could have put on this slide that would be correct. The key is getting multiple specimens over a time period and then continually following your patients, even if they don't have NTM initially,
Yes.
they may develop it, and so continuous sampling is quite important.
That's the key point, is that some of these patients progress over time. Everybody has a different slope. Some people develop little inflection points later, and you don't want to say, see you in 5 years, because that's when you run into trouble.
Yeah, so I'd say B is absolutely wrong. The others are okay, and probably the best is C. Okay, Dr. Hurtado.
All right, so we're going to start with a couple cases. So this is a patient of mine who was in her 30s from Southeast Asia. And she presented actually with, believe it or not, subclinical tuberculosis. And it's hard to imagine that with that CT she had subclinical TB, but this was as part of her sort of occupational health screening. She was joining as an administrator in a healthcare system and was ultimately noted to have culture-confirmed pulmonary TB, but she remained smear and culture positive, and this was sent to a commercial lab, so it lingered in the lab, and we were called because there was a concern that perhaps her drug-susceptible TB isolate had amplified and become drug-resistant because she continued to be smear positive, and there was a delay in the lab actually reporting this out and tracking these results at a smaller community hospital. But lo and behold, while she stopped growing TB after the first month of therapy for TB, her cultures subsequently grew Mycobacterium abscessus. So any thoughts on how to approach this patient, Dr. Winthrop?
We did a study in Oregon, again, population-based study in Oregon. If Oregon is generalizable to the rest of the country, I don't know, that's another question. But, we looked at all the TB cases over a couple years, and it was like 15% of pulmonary TB also will isolate NTM during their workup and treatment of TB. And a lot of that was MAC, some of it was Gordoni, some of it was abscessus. And, most of those patients, you just treat their TB and you deal with the NTM later. And the overwhelming majority, the NTM is never an issue. But, this person has underlying bronchiectasis and is different. So, I always say, hey, look, assess those people after they're done and make sure it's not an issue, because every once in a while it is, but usually it isn't. So.
Yes, great point. And the opposite sometimes happens, where they'll grow the NTM first and everybody gets excited about their MAC, and then you get the phone call a week later that they're actually growing the TB.
Yeah.
Yeah. She unfortunately continued to grow abscessus multiple times, and while she had a symptom, well, she was subclinical, so she actually put on some weight, but then did develop a chronic cough despite not growing TB. And so, Dr. Drizzo-Harris, what are your thoughts in terms of clearing this infection with this radiographic picture?
So I love this radiograph because I'm so excited that it's localized. And of course, we have to see all the cuts. But, when somebody comes to me like this is great. We're going to make sure we can get her on a regimen that she can tolerate, because we can't proceed to surgery without having good pharmacology going on. And then we're going to take that right upper lobe out.
Totally agree.
And that's the best chance for cure in someone with M. abscessus if you've got localized disease. She's not using any of that right upper lobe anyway, so she's not going to miss it when it's gone. But you have to be able to tolerate some therapy because you can't do surgery like that without therapy pre and post, and we'd want to do as much therapy as we can up front to try and get her to culture convert. If we can't, we'll go ahead with surgery and then continue for a year until we can get culture negativity.
Absolutely.
So I'm not sure what happened to her.
Yeah. So she, we were all teed up. She went on a very aggressive M. abscessus regimen, and then right 2 weeks before she was to undergo her surgical resection and her bacillary burden had decreased, she was diagnosed with the thyroid cancer, which incidentally, thyroid cancers are associated with increased risk of tuberculosis. But nevertheless, the surgery was delayed, and I have to say she's now 8 years out from her surgery, and then she also had a 1-year postoperative tail, and she's cured. And she's very grateful because this is the kind of scenario where there's clearly going to be stigmata unless you surgically resect in someone who's in her 30s, right? A life of misery with recurrent infections and other complications. Great. So this is a gentleman who had significant bullous emphysema, FEV1 of 0.8. and refractory MAC. How would you approach this, Dr. Idrizzo-Harris?
This one's a little bit more difficult. So he's got refractory MAC in that you've treated him now for 6 months. He's still positive?
Yes, this is a recent referral, so we're just now seeing him for the refractory piece.
So again, when we see patients who are refractory, we're going to go ahead and check drug levels, make sure that they're getting adequate. I don't know what his comorbidities are, and is he absorbing appropriately, et cetera. We'll do that first. We'll again make sure they're not aspirating, but probably not with this upper lobe disease. I'd still, even with that 0.8, I need to know what's his functional status like.
Yeah.
What does he look like? Can he walk down the hall without a problem? He's not desaturating. We do a VQ scan, perfusion scan. Still, my surgeons would probably want to look at him and consider looking at that upper lobe. It's upper lobe, that's good.
Yeah.
Probably not getting as much perfusion. Could he survive with us resecting that cavity? If you've tried with IV antibiotics, et cetera, and he's not responding. I don't know. Need to know his symptoms, and we need to know all of that.
Yes, and so he has a BMI of 20, recently lost his partner, and he has moderate functional impairment. He does get short of breath after about 2/3 of a staircase. And so our surgeons right now, we're optimizing him. He's currently on IV therapy. And we've also included clofazimine, which literally just arrived last week, hot off the presses. Our surgeons are not terribly excited, but I'm keeping the myth alive to see. We're going to re-image him in a few months and see. But it's going to be really tough because he probably will not be a resectable candidate. Kevin, any other thoughts?
I mean, my only thought is I actually think you can probably cure him medically. So if he hasn't seen IV amikacin yet or clofaz, I think he had those. I mean, the perverse thing about smoking-related NTM is that they're more likely to cavitary disease, but if you get them early enough, they're more likely you can cure them.
Yeah.
You can't cure the bronchiectatics, really, for the most part, but you can cure this, and that's not too bad. So I don't know, or, maybe if they're old and they're really not a good surgical candidate, you can keep them on suppressive 2-drug therapy and they'll probably be fine for years. So I think you have some options if you don't want to resect him or if the surgeons think the morbidity is too high.
Yeah.
And I don't know that we're sure that what's in his other lung is inflammatory, so I wouldn't forget about that.
Yes, he actually, I forgot to mention,
That's a good point.
the other lung was biopsied.
Okay.
Yes, because originally the reason for his delay is they were very much chasing the malignancy sort of angle, which is always important in these patients. So great, some tough cases. Stay tuned, and another patient update.
After meeting with your doctor,
Oh, somehow the volume's a little low.
NTM disease is, what MAC is Did you feel like you were prepared for the treatment journey ahead?
So I was very,
After meeting with your doctor, talking about the diagnosis and what NTM disease is, what MAC is, did you feel like you were prepared for the treatment journey ahead?
so I was very unprepared for my treatment journey. I think they tried their best to give me an understanding, but I feel like there were so many questions, so many unknowns. I actually went on the internet, on forums to try to figure out what was next, what's the process. I just was lost and I did not really know what to expect.
Okay, so not good. That's tough, and that's what a lot of patients go through. A lot of anxiety of not knowing how long this long journey is going to be. So what do you do? How do you counsel your patients? How can we help them up front? Rocio.
Yeah, I think some of the most common questions that we face, that our patients face, is how did this happen? What does this look like? Can anybody even get through these medicines? What else can I do? And so we try to always maintain a little bit of the locus of control in terms of what are the things that the patients can actually act upon, right? So airway clearance, some of the esophageal measures, the weight, and all of these things. And then we really, we try to give them hope. If they are going to undergo therapy, we often say, we can get 90+% through therapy. We do share sort of what the landscape is and what are some theories about how this occurred, and accompany them in their journeys. It's really sad that in the current era where hospital visits get shorter and shorter, it's harder to have time, but that upfront time that you invest in sort of mapping out the journey and walking it with them, it really goes a long way for patient engagement. Kevin, how do you manage in Oregon?
Chat GPT. It's made it a lot easier. I'm joking. I mean, I agree with everything you guys said. I mean, obviously, there's some good patient advocacy groups out there, NTM-IR, and now the Bronchiectasis and NTM Association. There's a lot of things you can give patients to educate them if you don't have the time in the office. So, some of us have staff that do a lot of that education piece after you leave the room. So I guess my biggest thing is just to be optimistic about it. I think it's kind of a myth. The medicines aren't that bad. They're a hell of a lot better than a lot of other things people have to take, and almost everyone can get through it. Our treatment completion rates are like 95%. So I think you have to be willing to be creative sometimes and work with patients. But I think if you spend the time and maybe do things differently if they need to do it differently, but you can get them through things. So I'm pretty optimistic about it all. So.
Yeah, and you don't have to have everything happen all of a sudden up front. You can take your time.
Yeah.
And I like to phase each drug in one by one. Try not to use azithromycin monotherapy alone, so we won't start with that. But I do like to know if they're going to have GI upset or a rash from one of the meds. And so we'll phase them in. There's no rush. It took them a long time to get to where they are, unless they're, really very sick. Most, you have that time. And so that urgency I'm feeling, I try not to put that onto the patient and let them know we will get there and they will get through it. As Kevin said, most patients get through the therapy. That's the majority. And the ones they sometimes do hear about are the patients who are having more of the difficulty, and I think that's a little bit of the fear. Yeah. Here is a downloadable resource for you. You can scan the QR code, the ATS-ERS ESCMID and IDSA put together this clinical practice guideline based on the current guidelines. So please use this as a pocket guide for you and your fellows and your other providers. And then let's talk a little bit about managing treatment. Here's a few questions we're going to go over. You now have a refractory MAC patient with pulmonary disease. Considering the guidelines for intensifying therapy, what do you do next? So they've been on 6 months of therapy and they're still positive, having positive cultures. Do you add daily amikacin liposomal inhalation suspension, add daily oral clofazimine, add daily oral moxifloxacin, or add IV amikacin 3 times a week? next question, there's a display on that one. We'll come back to it. Among the listed criteria, which is most likely to predict treatment outcomes in patients with pulmonary M. abscessus? Their smear status, their BMI, their macrolide resistance, or multifocal bronchiectasis? Okay. So let's talk, we're going back to our patient.
And during your treatment course, what were some of the main challenges you had related to the medications?
I really struggled with that, constantly trying to find the balance of work life and dealing with the side effects of fatigue and just not feeling good on a daily basis and having belly aches, body aches, just the struggle of life itself and finding the correct timing to take them. That makes a huge difference in being able to know what time might be better than another.
Were there specific non-medical interventions that had a substantial impact on your quality of life?
Yes, I feel like nebulizing on a regular basis definitely helped me feel better. I felt like I was breathing better when I did not nebulize on schedule. I would notice I'm clear in my throat, coughing more. So that was a huge impact, and keeping to it twice a day.
And how many subspecialists did you end up seeing, Angie, to help manage and control your NTM disease?
Oh my goodness. Multiples of the same specialist. I think I'd added up at one point, and it was probably 11 or 12 different doctors, but I was very blessed because they all communicated and worked well together.
Okay, so some issues with treating patients with NTM lung disease. The significant toxicities from a lot of the medications and limited intensification options. So what do you say to your patients about the side effect profile? How do you approach that with MAC or with M. abscessus, Rocio?
Yeah, so I do give them hope and say we have a very good track record of getting you through, but you need to be aware that we may need to do detours and we may need to do some drug holidays, so don't expect a straight road. And I think that gives them a little perspective that even if we have to do those things, that it doesn't mean that we're throwing the towel. We're still by them, we're still pushing through. But a lot of the staggering, sometimes nighttime dosing, and we'll talk a little bit about that in a few more slides
Right.
as well.
And patients often want upfront an exact plan of what the road is going to be, and I try not to give them that. I tell them we're going to take this
Day by
1
day.
week and 1 month at a time because it is so variable in every patient and it may change. And as long as they know there's that ability to communicate and that we are on top of it, I think we can kind of get through that together because everybody wants to know the answer, and we don't have that. So it's better not to go there and just say we're going to take it a step at a time.
Yeah.
I know you
agree.
like that, Kevin.
No, I
You're-
totally agree. It's very case dependent. It's very individualized. I think,
Yeah.
So, yeah.
So treatment regimens for MAC, many of you probably know these, but I'll just go over them. For nodule bronchiectasis disease, we're going to recommend 3 drugs 3 times weekly. This is what's in the guidelines. There's some evidence out there now from a study that Dr. Winthrop did, a multi-center trial, that 2 drugs may be almost as good and better tolerated, but it's not yet in the guidelines. So in the guidelines are recommending azithromycin over clarithromycin. Dosing is different for 3 times a week, so it would be 500 milligrams 3 times a week. Rifampin is preferred over rifabutin at 600 milligrams 3 times a week, and ethambutol at 25 milligrams per kilogram 3 times a week. It's very well tolerated, very low side effect profile, and we know the most difficult drug in this regimen is the rifampin usually, and so that's why some of us are moving towards azithromycin and ethambutol in the correct patients. Cavitary disease, we're going to want to do the 3 drugs probably with IV amikacin. In most cases, that IV amikacin is 3 times a week, and the meds are daily. So azithromycin at 250, rifampin at 600, that stays the same, and ethambutol is now just 15 milligrams per kilogram. And then when we get to refractory disease, this is going to be someone who's still positive at 6 months. We usually will be adding amikacin liposomal inhalation solution suspension. Sometimes if the patient's progressing, you may need IV amikacin. We talked a little bit about adding clofazimine. In some regimens, clofazimine is the third drug, very widely used in Canada. Often a number of studies not inferior to azithro, rifampin, and ethambutol. So again, looking at your patient, looking what you have available, looking at their comorbidities, et cetera, is going to play a role in making a decision in that therapy. Here is your treatment framework, a nice flow chart for you. This is for macrolide-sensitive patients, so the guidelines do recommend getting your antimicrobial susceptibility on your MAC, making sure that only 2 antibiotics you're concerned about are macrolides and amikacin, making sure that you are sensitive to those 2. If you send it to a lab and it sends you back ethambutol resistant, rifampin resistant, do not pay attention to that. We've had many physicians who've stopped everything and have only gone with what's been sensitive, and then we see patients on azithro and a quinolone, and they ultimately become azithromycin resistant. So you're only looking at macrolides and amikacin for your sensitivities for MAC. You're going to go follow this chart. If they have cavities, we're going to be more aggressive, daily therapy. In the center shows you some of the alternative drugs that we have. Clofazimine. We don't use quinolones for MAC in most cases. It's really salvage therapy. Bedaquiline has some effect with MAC. Inhaled amikacin here is different than your liposomal amikacin. So if you cannot get off, we're not going to talk about upfront therapy. Upfront therapy right now, liposomal amikacin is not approved for upfront therapy, only for refractory, although the ENCORE study results were released at this meeting, and we are hoping that liposomal amikacin will be available to treat patients upfront. In that study, it was azithro, ethambutol, and liposomal amikacin upfront with outstanding results compared to just azithromycin and ethambutol alone. But if you need to use parenteral amikacin, you can use it inhaled, 500 milligrams mixed with saline inhaled. In the old days, that's what we were using, and that proved to be effective in many patients. And then this is just looking at your chances of culture conversion. Most patients, 50 to 80% will culture convert, but look, we've got 25 to 50% that will recur, and in that group, half and half reinfections versus relapse. In your patients that are treatment refractory, start making sure you did a good etiologic workup, make sure they're not having microaspirations, make sure they're absorbing, make sure they still have drug-sensitive MAC, macrolide-sensitive MAC, and then think about adding amikacin liposomal inhalation suspension. Not only does it help culture conversion occur quicker, but there's a durability effect so that patients that get amikacin liposomal inhalation suspension are not recurring like we're seeing in some of the older studies when it wasn't used. And this is one of the first studies showing the benefit of amikacin, of liposomal amikacin inhaled. The CONVERT study shows that patients, and these patients were treated many years and were not converting. In the group that was put on liposomal ALIS, or liposomal inhaled suspension solution with amikacin, was 29% compared to those who were not, 8.9%. So a strong recommendation for using ALIS therapy in refractory patients. I'm going to, before we go on to that, is there anything else that you want to add about MAC?
I just wanted to echo what Dr. Rodrizo-Harris said, that the ethambutol protects the macrolide and that you should avoid at all costs losing the macrolide. So avoid using monotherapy azithromycin, avoid keeping people persistently positive for months without end, that's another big risk factor, and avoid using quinolones during MAC treatment. The Moxie, I believe, there was only a potential option in patients who are already macrolide resistant, but not for patients who are macrolide susceptible. So if you can remember those three things, you will do a service to your patients. Kevin, anything?
Nope, I think you hit it. We don't use Moxie or Levaquin. It's probably only 3 or 4% of isolates
Yeah,
are
very
susceptible
rare.
anyway, so it's pretty unusual.
Yes, and so one of the common sort of missteps we see is if patients develop a rifampin or an ethambutol-related reaction, that because it's hard to get access to clofazimine, that oftentimes the mistake is made to substitute for the quinolones, and that's when we run into problems. So don't do that. Refer to a center, and the centers will help you get the drugs they need. So we're going to switch gears and just briefly mention that M. abscessus, of course, elicits the fear of God into many of our patients and in physicians, and the number one predictor of outcome is macrolide susceptibility, inducible or mutational. So once you have inducible or macrolide resistant disease, your chances of sustained culture conversion go down to less than 40% in most series. And so the lab piece in terms of helping us stratify what this is going to look like is extremely important. And so, of course, the University of Texas Tyler really described the gene and inducible macrolide resistance, but be very careful about the hospitals are contracted with, because not all commercial labs are necessarily screening. And so even if they don't screen for the gene, they have to incubate for at least 2 weeks. We won't go into the particularities of M. abscessus for the purpose of this talk, but you can look over this, and we traditionally start with ideally 4 active drugs. If the isolate is macrolide resistant, while you can include a macrolide for immunomodulatory purposes, you do not count that as an active drug. So really making sure that you have active drugs, and the most common IV agents that we use are IV amikacin and imipenem, and then we don't include a slide here, but Kevin was actually the PI on an omadacycline monotherapy phase 2 study. And Kevin, do you want to mention a little bit about your exciting results?
Yeah, it was just published in CID a couple months ago, Clinical Infectious Disease Journal, but it was a 3-month monotherapy trial. We actually got about 50-some% of people to clear the sputum with just omadacycline by itself. So I don't know how long that lasts. We didn't follow these people beyond that, but I think it showed that the drug is active and it works. So it's certainly it's a drug that I employ in all my abscessus multi-drug regimens. So.
Yes, and so we do that as well. And so the other thing is for carefully selected patients, and we saw at least one of the 2 cases was carefully selected for patients who have treatment-limited disease, and that's defined as patients who have appropriately anatomically resectable disease, refractory disease, or complications. So that could include massive hemoptysis with adequate pulmonary reserve and an optimized nutritional status as well. In the hands of an experienced thoracic surgeon, these are patients who we typically will do, as Dr. Idriso-Harris mentioned, a sort of leading therapy, typically at least a few months, reduce the bacillary burden if you can, and then they can undergo the resectional surgery. It can be life-saving for some of these patients who are persistently culture positive, and I outline here the incredible sputum culture conversion rates according to species, and in the appropriate hands, the rates of complication have really gone down in the last 20 years. This is more for your perusal reading. This is a patient of mine who had pulmonary alveolar proteinosis and localized M. abscessus, and his kids brought him to me saying he's been told he's going to die. And I said, well, give me a few months and we'll get him to surgery. And he's now 15 years out and is doing great. And so this is now incorporated into the guidelines for those appropriately selected patients. Dr. Idriso-Harris, any comments on surgery for your patients? How often do you use it in your center?
So we think about it always, and anyone with localized disease, and in those patients who may have disease where a large cavity, even if they've got diffuse disease, but you can kind of debulk them, depending obviously on the case. We do most of our surgeries, almost all robotically now, and patients will often go home. I know a surgeon wants to send them home same day, but most of the time the next
Yeah,
day.
that's great.
And they're going home with sometimes chest tubes still, but that are monitored at home. And so most of them do very, very well. We published a small series, but yes, thinking about it early in any patient with cavitary disease is extremely important. And then referring them to a center that has an experienced surgeon is critical.
Yeah, I do it at a place that does a lot of these.
Yep.
Yeah.
That's my advice.
Absolutely. The surgeons will often say that a resectional surgery for lung cancer is way, way easier than these. And so you really need an experienced surgeon. All right, we're in the last portion of this. Lots of complexities. This is really a team sport. We talked about microbiologic recurrence being very high with a significant proportion of reinfections noticed. Always remember that we have to continue to optimize all their comorbidities, given how common and critical they are. Always ask yourself, is there a surgical option? And if there is, that's actually an incredibly positive thing. So frame it as such for patients. And then think about salvage in the appropriate patient who's refractory. Document the susceptibilities, make sure they're not amplifying, consider therapeutic drug monitoring in selected patients, and let the patient know what lies ahead. So this is really, really a big road trip for the patient, and a lot of these things we've discussed already, so I'm not going to really delve on this, but really always also incorporate the patient's goals and values. This is a lot of our decisions along the way are engaged via shared medical decision making. And then also know what are the critical adverse events that you need to monitor for and how to manage, and always communicate and support the patient in their journey. So post-assessment time, let's go back to our question. Patient with refractory MAC, what do you do next for intensifying?
It's going to be 100%.
I know, should be. Answer is inhaled liposomal amikacin. That's the CONVERT trial that Dr. Adrizzo-Harris noted, fourfold increase in culture conversion. All right, now patient has refractory MAC. That's one. So last section, and this session is really focused primarily on slow growers, is really looking at some of the common toxicities that we should be aware of in this patient population. So the macrolides, remember the reason the guidelines prefer azithromycin, one of the major reasons azithro over chlorithro is that the GI toxicity profile is more favorable with azithro. Remember, azithro is more ototoxic than chlorithro, so on occasion, we actually have to go back to chlorithro if there's significant ototoxicity because we like to preserve the macrolide if at all possible. And remember that these can rarely be associated with hepatotoxicity and hypersensitivity reactions, but typically this is very uncommon. Ethambutol. Ethambutol really protects the macrolide, so if at all possible, maintain it in the regimen. The major side effect that we're monitoring for are the neuropathies, in particular optic neuropathy. And I know, Kevin, you've done some studies in terms of how common this is. Do you want to make a little comment about that?
Well, it's definitely age dependent and dose dependent, but when we looked at our population, it's about 1 in 350. So, I mean, it's rare, but it's, it's more than a few per thousand. So.
And the thing that I want you to remember is patient education is key. You have to tell the patient that if they, and oftentimes we'll ask, in addition to having them schedule with ophthalmology, we also ask them to do the Ishihara one eye at a time, weekly at home, but also educate them that it's not just the color vision. Sometimes it's just the inability to read fine print, and if they notice a change, they are not to just say, oh, I'm going to see Dr. Adrizzo-Harris in a month, it's not that bad, I'll just push on. They are to hold the ethambutol, get evaluated, because it's really the people who continue on the medicine. I had a patient recently that despite extensive education, she was going to see me 2 weeks later, and she didn't. She was out of state and traveling and didn't want to bother, even though we had told her to please let us know. And by the time that 2 week rolled around, she could no longer see the highway signs. So you really, the patient education is key. Rifampin is our problem stepchild. The drug-drug interactions, and it is of the 3 drugs, the one that's most apt to cause intolerance. Nighttime dosing can sometimes help, and always be vigilant about those interactions. In fact, many a times for our cardiac patients, we need to preemptively change things around before we place them on rifampin. Amikacin, of course, can be cochlear toxic. Also, there's renal toxicity with the IV formulation. The liposomal formulation has a much better profile in terms of both the ototoxicity and the nephrotoxicity, but the respiratory piece, including not only the cough and bronchospasm, but the dysphonia can be quite prominent. And so I want to stop here and ask Dr. Adrizzo-Harris and Dr. Winthrop to share some of their tips and tricks with how do you handle and how do you use inhaled liposomal.
Want me to go first?
Sure.
So, you can get anyone you want on inhaled liposomal amikacin, but it takes time. Patients often will have dysphonia, cough, bronchospasm, and particularly when they started up front 7 days a week, and that's what the trial is, and that's what the label is. However, I tell my patients we're going to start a little bit slower, and we may just do Monday, Wednesday, Friday to start to make sure they tolerate it. Their vocal cords need to get used to it. We've got patients on it 9, 10, 12 months. They don't even know that they're inhaling it. They just love it, and it does the trick. So it does take that time in some patients, so beware of it. Sometimes using a bronchodilator with albuterol is extremely important. Knowing which patients are going to need that. If you've got somebody who's already a little bit bronchospastic, recommend that up front, because otherwise patients will get frustrated. They'll call you 2 days later. They can't tolerate it. They can't speak, and it just becomes very frustrating. So we really do. I'll go 3 times a week, then we'll go 5 days, give them the weekend off. If they're on 7 days and they start to get hoarse, give them a day or 2 break, and then tell them to restart it again. But you really can get everybody on it. It just takes a little bit of trial and error.
Yeah, no, I agree. I'm a 3 times a week starter, and I think that really helps. You just go up from there. So
Great. We do that too. I'm going to move on in the interest of time. Nighttime dosing, staggered introduction. Be very aware of split dosing. These are concentration-dependent killers, so you don't want them splitting their rifampin or their ethambutol. Maintain their hydration status, and on occasion, a drug holiday may be needed. Back to the last segment.
One thing that was really reassuring once I was negative, once I came off the meds, because you just get really scared, not knowing what your future looks like. And it's good knowing that you can have it again. Doesn't mean you have to be treated yet. You could be treated, not necessarily all of the antibiotics, and just being reassured that this is something that can be managed along the way. If you are to culture positive again, that normally you're healthier at that point and it'll be easier to manage it. You're not that sick person that came in originally and just got hit with all of the heavy meds because they needed to get on top of it.
Well,
So one of our final questions, what strategies do you typically use in your own clinical practice to support your patients, including their quality of life as they navigate their journey? Kevin?
I think we've covered it.
Yeah.
I think we should get to the questions.
Let's get
That's
to
what
the
I think,
questions. Post-assessment.
Yeah.
Dr. Winthrop's getting antsy.
No, I just think we
Just
talked
kidding.
about it.
All right. Amongst the listed criteria, what predicts treatment outcomes? Oops. You know, I think we might,
Just go.
yeah, let's just go.
I think they need that.
Yeah,
need
we
the
need-
scoring.
Yeah. All right.
Go ahead and vote.
Somehow the, okay, here we go.
I think they need the question.
Oh, I don't know. Good, yes, macrolide resistance, that is the key. And remember, mostly it's inducible resistance and you have to look for it, so. I think we've covered a
Yeah,
lot of
we've
this.
covered
I
that.
mean, watchful waiting, it's really hard, as Doreen said. We don't always treat everyone, but if you spend 3 to 6 months sorting out your patient, educate them, work on hygiene, I think you go from there. And I think we've probably covered the rest. So let's get to your questions because we are running out of time. Should we do it? Actually,
Yeah, I think
there is
we've
this
got the
mention about
Encore and the
frontline
Arise.
therapy. This is
Yeah.
important. We're not going to get into it, but Dorian mentioned it. It's not published yet. It's not in the guidelines yet, but very encouraging data with ALICE being added to treatment starts. So higher rates of culture conversion, better PRO scores or patient-reported outcomes. So I think that's coming. So just park that one for now. So, Rosia, questions?
Yeah. Should we do the CCN before we don't have that many, thankfully, but Doreen, do you want
Yeah,
to mention
Doreen
the?
mentioned this, yeah.
Yeah, so we've started with the Bronchiectasis and NTM Association, which is an arm of the COPD Foundation, the Bronchiectasis and NTM Care Center Networks. I'm thrilled to be the clinical chair along with Dr. Daly, who's one of our faculty in charge of research, and Dr. Axelman in charge of education and awareness. Dr. Winthrop sits on our steering committee as well. We now have 62 centers across the country. The goal is to get up to about 100. If you happen to be a physician who's interested in starting a center, let us know. We will help you put it together. There is an application process for those wanting to become a CCN site, but to just let you know, there's a lot happening in this community. We've got a brand new website that's being launched with the Bronch and NTM Association, and lots of information can be found on that.
Great, thank you,
Fantastic.
Rosia. A couple questions
Yep,
from
we
the
got a
audience?
couple questions. The first one is for Dr. Adrizzo Harris, and she's the pulmonologist in our panel. If a patient is a smoker, what do you do? Do you treat the tobacco dependence first, or do you treat the NTM, or how do you manage that?
We're lucky that most of our patients are not smokers, but I'm always going to treat tobacco dependence as soon as I can, so that's going to go in parallel with me doing everything else.
Yeah, totally agree.
Excellent. Second question is, what strategies have you found helpful when patients become discouraged after going through the revolving door of recurrence?
I send them to NYU.
Thank you. So there's a lot of programs out there other than the, we mentioned that a lot of the states have their own patient advocacy groups and patient groups that they can get together. There's an ambassador program through the Bronchiectasis and NTM Association where patients can talk to another person confidentially, one-on-one, who's been diagnosed with bronchiectasis or NTM already. We actually are lucky enough to have a social worker psychologist in our program, so that's another resource. And referring them to someone in that area is often helpful.
Agree. I think there's a lot more resources now than there were 5 years ago. So.
Couple questions on fatigue being a very common scenario for our patients. How do you manage fatigue? And is there a valid fatigue-related score that you use in the clinic?
You know, the fatigue-related scores that we've looked at in trials haven't been very responsive to treatment, so I don't know what to tell you about that. Other than fatigue is definitely part of the disease. It's also part of rifampin sometimes. I happen to think exercise is the best way to deal with it. I really, really try to get everyone on a 3 or 4 times a week cardiovascular, aerobic exercise program. I think it's really important. So that's what I really spend time with my patients. I don't know.
No, I agree. Exercise and addressing anxiety and depression sometimes can fix the fatigue issue.
Agree.
Excellent. We have some questions here about when do you screen your MAC patients for immunodeficiencies?
Almost never. I mean, if they have extrapulmonary MAC, then absolutely. If they have pulmonary MAC, almost none of it's linked to immunodeficiency unless they're on agents that cause immunodeficiency. So, I mean, TNF drugs, for example, or prednisone, things like that, or inhaled corticosteroids. I mean, so there's things that you'll screen, I guess, technically when you work them up. But almost very, very, very few of those people have inherited or acquired immunodeficiency. So.
Great. And can perhaps Dr. Drizo-Harris can comment on your approach to when do you discontinue inhaled corticosteroids on patients who are on those? And is there a difference or dose or amongst the different varieties of ICS in terms of
So we know the
risk?
incidence of MAC is dose related, and so I will certainly, there are a percentage of our patients that do need inhaled corticosteroids that have asthma overlap, maybe severe COPD, high EOs, they may benefit from that. They may also should be on biologics, I mean, depending. But if I have a patient where it's very unclear, which is the majority, we stop everything to start. And then we start to look at them fresh and see where we need to go from that. But they're in the registry, we have, I think, I don't know, percentage, probably close to 50% we're on ICS. And so I think that's probably at least double what need to be on it. And I know you've done a lot looking at the increased incidence.
I agree with that. I mean, we usually try to stop it and see if people tolerate stopping it. If they don't, then you got to make a decision about, what dose and what to give them. But I think, I mean, definitely no question, some people need to be on them. So.
Question is, why do you have to try to suppress NTM before surgery?
Well, there's data from, I mean, they've published, we've published, Mitchell at National Jewish has published. I mean, outcomes are better if you're culture negative from respiratory samples. If you've got tissue negative from the lung, outcomes are better. Abscessus is a nasty bug to resect. You can track it through the subcutaneous space. I mean, I've had people with pleuritis and chest wall infections from abscessus. So, I mean, the less culture positivity there is, the less bacillary burden, the better their outcomes. So.
And on that question too, how often do you do bilateral resections? We do a fair bit of them. We do them two-stage, so we don't do them at once. How about your experience?
Yeah.
Yes.
Yeah, particularly middle lobe and then lingula.
Yeah, two-stage. Yeah.
Quick question that I'll answer. Why are you avoiding combining quinolone with macrolide? We answered that. So very few isolates are quinolone susceptible, and use of quinolone is a risk factor for macrolide resistance, so you don't want to use that in MAC. All right, so a few more questions. Is there any value to documenting in microbiologic recurrence whether it's the same strain versus a new strain?
No. It's interesting, but no, I mean, you have to genotype it, and it's not commercially available. I don't think it matters.
It sometimes helps it doesn't matter in terms of the management, but it sometimes gives a narrative to the patient where they can sort of line up again if they need to be treated. But
you can't really
hardly
do it.
ever do that.
I wouldn't worry about doing it. I think Doreen's point was important. We all learned that people get reinfected from
And we don't want them doing high-risk things like hot tubs and steam rooms and indoor swimming pools. That's a question. If that's the only activity they're doing and they're not that sick, I tell them exercise. So you've got to balance all of those things.
Power washing. It's deadly. Anyway.
Got a couple questions about M. abscessus and transplantation. What are the rates of recurrence? I'll answer that. The rates are actually about 30%, including dissemination. So a lot of centers don't use that, don't allow it, but what's your experience, Doreen and Kevin?
Our center does not allow it, so they need to be culture negative prior. There are phage therapy programs in the country for CF. At National Jewish, they've got a program, and we actually have one for non-CF bronchiectasis with MAC. With M. abscessus or MAC. But yes, they.
I think you try to clear those people, and phage is if you can get a phage that matches, that's worth trying. So.
Yeah.
Very well. Let's see. They're coming in fast and furious. Oh, can you comment on shower head management? Do you use bleach? What do you actually tell patients about exposures?
I'll let Kevin go first.
Yeah, I can't comment on it, actually. I just tell people to take short showers or to take baths. I mean, I think there's really no data. There's no firm idea what filter or how to deal with your shower head that makes any sense in terms of, I mean, there's no data to support doing anything. So I usually tell people to worry about other things that are definitely more modifiable, like avoiding the hot tub, things like that. So I don't know if you have a different
No,
take on it.
I think it's
but,
really
yeah.
difficult. You don't know where the biofilms are in your plumbing. It may
Yeah.
not just be in the shower head. It could be the 20 feet before that. So,
Yeah.
rainfall showers, whatever doesn't humidify the steam is better. So cooler showers, ventilation,
Put your
that
fan
type
on.
of stuff.
Yeah.
Put your fan on.
Yeah.
But, I don't actually tell patients to just take baths. Most patients want to continue showering, so
Yeah.
limit them
And I want most of my patients to continue
Yes,
showering.
I'm sure. I'm sure.
I agree.
Sure.
Yeah.
Dr. Drizzo-Harris, this one's directed to you specifically. How do you manage the patient who has difficulty with adherence and continuity of care? They may come on and off of therapy, and it's sort of hard to get them to be consistent.
Well, I question then, do they need treatment? Let's think about it again, because there are patients that I decide to treat, and boy, maybe it was the wrong decision in certain patients. They're worse, they're feeling worse, they're anxious, they don't come, so in that case, we think about it and we say, you know what, maybe we're going to give you a break and we'll see
Yeah.
how you do off treatment.
Totally agree. Yeah.
We do have, it's outreach too. It's having the resources to reach out to patients, to get them. We work with a lot of our patients at Bellevue Hospital. It's another site of ours, getting patients to have the ability to come to clinic as frequently as they need to or get blood testing. Sometimes there's a impairment. So we do virtual visits. We're licensed in a few states. That helps patients so that they don't have to physically come. So, really just trying to adapt to the obstacles that they are dealing with is what we try and do.
Excellent.
Last question.
Last question. This one's a very good one. For patients who become culture negative for treatment for MAC, can you ever, post-treatment completion, use the macrolide like azithromycin if there's underlying bronchiectasis with frequent exacerbations or COPD?
So, yeah, it's a big question. Can you use a macrolide alone as an immune modulator in someone who's had MAC before? The answer is yes, but I never do it because I'm never convinced I got rid of the MAC, or I just think there's such high risk for getting it back. I almost never do it. Sometimes I put people back on ASI with ethambutol just because I'm so worried that there's still a macrolide there. That's not something we recommend, but I do it sometimes.
Yeah, so we do that frequently.
yeah.
If we're using it for anti-inflammatory, we'll do
yeah.
it with ethambutol, as they're throwing ethambutol, even if I don't think their MAC needs to be treated. But now we have
Yeah.
a new DPP-1 inhibitor, FDA approved, so that's our go-to.
Yeah.
And we don't want to have to worry. You just have to see 1 or 2 cases of macrolide-resistant MAC, and those patients do not do well. So,
totally agree.
yes.
Yeah.
So DPP-1 inhibitors are,
Yeah, I think it's a lot easier.
Probably
You're not
much
going to get
easier.
resistance with brensocatib.
Yeah.
So,
Right.
well, I think we're over time, so I'm seeing this thing flashing at me. So I'm supposed to thank you for participating in this symposium. And to remind you to claim your CME credit because you had to sit through this, so you deserve to get something out of it. So please do that, and thanks very much. Appreciate it.